Um, this is Kelly at Spectrum Health. I'm the Parkinson's Nurse Navigator, and I want to thank Mary Sue with the Michigan Parkinson's Foundation, not only for coordinating with us tonight, but for all of the events we've been doing. This great to have turnout from so many people. We have an excellent presentation tonight. Many people, many patients I work with, they're always asking, understandably, about cognition. And we have Dr. Bertram here tonight to talk about cognitive, emotional, and neuropsychiatric considerations for Parkinson's. Dr. Bertram is one of our neuropsychologists at Spectrum. He has an excellent pedigree. He earned his master's degree and doctorate in clinical psychology from the University of Indianapolis. He completed his pre-doctoral psychology internship at Cincinnati Veterans Affairs Medical Center and his neuropsychology postdoctoral fellowship at the St. Louis VA Medical Center. He works with patients with Parkinson's disease, as well as stroke, traumatic brain injury, and dementia. So we're really honored to have him here speaking tonight. So thank you for your patience, and I'm going to turn this over to Dr. Bertram.
Okay, well, thank you, Kelly, for that introduction and for all that you do to set this up. And thank you to all of you for allowing me to be a part of your evening. I'll try to be respectful of time. Do we have a way to, if questions pop up, is that going to show up on the chat?
Yes. Bertram, this is Mary Sue. I'm with Michigan Parkinson Foundation. I'll be advancing your slides, and yes, I will be monitoring the chat. Okay. Okay.
Yeah, that's great. Thank you.
Right.
You know, it's funny. I had a little bit of technological difficulty signing on through the computer, but recently my colleagues and I were talking about some of the benefits of actually doing virtual visits, virtual appointments, and these meetings. And one of my colleagues said, "Well, it's nice we don't have to wear masks." Another colleague said it's nice to be socially distanced. And my section chief said, "Well, pants are optional." That's the part that I like the best. So, we've all got different things. If you don't mind, the next slide. I have nothing to disclose, but what I will tell you is I have really cute kids. Odds are you will probably hear them screaming at some point during this presentation. But if you can hang in to the end, I'll show you some pictures of them. Okay. So on the agenda today, I was hoping to talk about both cognitive, emotional, and neuropsychiatric issues in Parkinson's disease. You know, a lot of times when you go to support groups or you go to presentations or you meet with the medical providers, a lot of the emphasis is really on the motor issues in Parkinson's disease. And those issues absolutely deserve adequate attention. They're debilitating, they're significant, and they need to be addressed. But we also have non-motor issues that come up. And we do need to pay attention to those things. So that's what I'd like to talk about today. And we'll start with cognition. Okay, next slide. So cognition in Parkinson's disease, you know, what is cognitive functioning? Different people will describe it differently, but our cognitive abilities are essentially what allow us and our brains to meaningfully interact with our environment. Memory, attention, problem solving, reasoning, etc. It's important to note that neuropsychology is interested in brain behavior relationships. What's going on in our brain and how does that impact our ability to interact meaningfully with our environment? It's also important to note that everyone has different relative strengths and weaknesses. My wife is incredibly verbal. She has the gift of gab and she can process through things verbally very, very well. I tend to do better with my visual spatial functioning. I can see things in my mind's eye. I can put things together without instructions most of the time. And so everybody has different strengths and weaknesses. And so we have to keep that in mind whenever we're talking about our cognitive abilities, because people are just wired differently at baseline. Okay, next slide. So interestingly, in some of the early publications on Parkinson's disease, even in the essay on the shaking palsy by James Parkinson over 200 years ago, it was noted that the medical community largely felt cognitive functioning was unaffected in Parkinson's disease. As life expectancy has increased, as we've done more research on Parkinson's disease, and as more people have developed it and we've better understood it, we realize that there is a significant risk of actually experiencing cognitive changes in Parkinson's disease. It's about 600% more than age-matched individuals who don't have Parkinson's disease. What we tend to see, just generally speaking, is you might see this term frontal striatal or frontal subcortical weaknesses. And all that is we have a lot of communication that occurs from the frontal lobes, the front part of the brain, to the middle part of the brain that's responsible for carrying out a lot of our movement. And the communication between those two areas gets disrupted. What we tend to see is that people with Parkinson's disease, they may process information a little bit slower. We may have more difficulty with multitasking or working through complex tasks. Or we can see this thing we call a memory retrieval issue, where we have difficulty pulling information out, but when we get hints and reminders, that information has been accessible. But the bottom line is the cognitive changes are actually pretty common in Parkinson's disease. And the older you get and the more the disease progresses, the more likely it is that we will see some cognitive changes. So next slide. So what do I do? So, you know, a typical neuropsychological evaluation, you know, involves me receiving some type of a referral, either from your neurologist or your primary care physician, and the indication for the referral is included. We've got some memory concerns. We've got a 5-year history of Parkinson's disease, and, you know, Bob or Sue is having a little bit more difficulty quickly working through information. So once we get the referral, I go through your records, and we set up a time to bring you in for a fairly lengthy evaluation. I first conduct an interview where I talk with you, the patient. I talk with any collateral reporter that you might be able to bring with you. And I just get some history. How's your memory working? How's your attention? What have you noticed? When did it start? Has it gotten worse? Has it stayed about the same? And I'll also get other important background information from you. I try not to reinvent the wheel with medical history because I have all the medical records, but I'll ask you about school, family, work, just all kinds of background information. The reason that I spend that time at the start, and pretty much all neuropsychologists do, is I don't know what we're going to do for your testing until I talk to you first. It's a very individualized evaluation. And that's why the formal testing process can range. It can sometimes be as brief as an hour evaluation, and sometimes you know, we torture you for up to 3 hours. There's no needles, no wires, we don't poke or prod, we don't analyze your dreams, we don't show you ink blots or anything like that. But we give you some very structured and standardized tasks where we ask you to remember things, work through some tasks that seem like puzzles or games. We give you very specific instructions. Once the testing is completed, that's really when the work starts for us, when we start going through the data and analyzing it. We compare your performances to people who are similar in terms of age, education, ethnicity, sex, handedness. All of those things factor into interpreting the data. Once we know exactly what's going on, we sit down, we give you a feedback session, we go through recommendations. Hey, maybe we need to consider a referral here, or hey, here are some things you can do at home, or hey, let's talk about this new procedure or this medication that's out there. It's really very custom tailored. And then we send a report back to the referring provider just to make sure that everybody's on the same page. Next slide, please. Thank you. So, you know, we have a residency program, and I'm one of the training directors, and very often as the residents come through, they express some interest in Parkinson's disease. And one of the questions that I always ask them is, what's the typical cognitive profile of Parkinson's disease? And the correct answer is, there isn't necessarily a typical profile. We say there's a lot of heterogeneity, a lot of variability. But we can see some issues with, obviously, motor functioning. We can see issues with attention, executive functioning, which is like the planning, problem solving, dealing with complexity. We can see slowed thinking speed. We can see some memory issues. We can see that word finding difficulty where you know the word and you just can't quite pull it out. And in some folks, we can see that visual spatial abilities aren't necessarily where we would expect them to be. But the general theme here is there's a lot of different stuff that can get impacted. Very rarely do we see, across the board deficits in all of these domains, but variability both between and within domains is fairly common. Next slide. Okay, so another thing that I think is important for folks to understand is if you look at the yellow arrow at the bottom of the screen, what I'm communicating is that in Parkinson's disease, it is possible that we can see progression of cognitive decline. Now, if you look at these three boxes, the box on the left, the blue one that says normal aging, and compare where that sits on the arrow, you can see that there is cognitive change that occurs as part of the normal aging process. If you are in your 70s, odds are you can't run as fast as you could when you were a teenager. Same thing can be true of your memory. As we age, our memories aren't necessarily as sharp, but we do see that as part of the normal aging process. Once we see cognitive changes on testing, and they're usually evident to the individuals with the cognitive issues as well as family, friends, and loved ones, if we can't account for the amount of cognitive change as a result of the normal aging process, sometimes we slip into this middle box, this mild cognitive impairment, which is exactly what it sounds like. We've got some cognitive weaknesses. They're more than we would expect by the normal aging process, but really there's no major functional fallout. We're doing okay in day-to-day life, and it's just mild cognitive weaknesses, so we call it mild cognitive impairment. Unfortunately, sometimes we see such a progression of cognitive decline over time that we can slip into this sort of light red or pink colored box where we experience this thing that we call dementia. Next slide, please. So I'm going to explain what dementia is, but in order to have an actual dementia in Parkinson's disease, a few things need to be present. First of all, in order to have a dementia in Parkinson's disease, you first have to have Parkinson's disease. If you don't have Parkinson's disease, you can't get a Parkinson's disease dementia. Okay? The dementia process itself is typically slow. It evolves over a number of years. It's not a falling off a cliff. It's usually this gradual decline over years. So we call it slow or insidious. And depending on who you ask and what reference you're citing, they will say that dementia, in order to have it, you have to have a certain cluster of symptoms. I'm a little bit old school and tend to consider the three boxes at the bottom of this page as necessary in order for me to classify something as dementia. So the first thing that needs to be present is you have to have cognitive impairment in 2 or more domains. Some people would argue 1, but I usually throw quite a bit of research at it and say, yeah, I like 2 or more domains. So it could be memory and processing speed. It could be memory and problem solving, but 2 or more domains. The second thing that has to be evident is that any of the cognitive impairments that are present have to represent a decline from long-standing abilities. So if somebody has always had difficulty in a certain cognitive domain, like think about somebody who has attention deficit disorder, or people who have had, long-standing issues with reading or academic abilities, some of their cognitive performances might fall below expectations, but if that's not a decline from where they were, then it doesn't really count. And the third thing that we have to see is there has to be evidence of functional impairment. Now, the functional impairment has to be a direct result of cognitive change. If we have a tremor-dominant Parkinson's disease and that's impacting our ability to button a shirt or tie a tie, that doesn't count. That's not a cognitive issue. That's more of a motor issue. It has to be something like can't manage the finances anymore because we're forgetting to pay bills. Can't manage medications anymore because we're forgetting to take them. It has to be a direct result of a change to cognition. So next slide, please. So dementia is a syndrome. And a syndrome is a group of symptoms. And the symptoms were on that last slide, right? We have to have the cognitive impairment in multiple domains. We have to have a change from our longstanding abilities, and we have to have some functional limitations. So that's the syndrome, the group of symptoms. But dementia is also a category. And so if you think about fruit, fruit is a category. And just as there are different types of fruit, apples, oranges, bananas, etc., dementia is a category, and there are different types of dementia. Now, Parkinson's disease itself is the second most common neurodegenerative disease. Number one is Alzheimer's, but you can see Alzheimer's is actually a type of dementia. If you develop a dementia in your Parkinson's disease, we call it a Parkinson's disease dementia. There are some folks who can have strokes. They can have what we call cerebrovascular disease, and they can develop what we call a vascular dementia. But it's important to note that it's a group of symptoms, and it's also a category. Can you do the next slide? So, you know, depending on where you look in the research and who you talk with, they can give you some different statistics regarding the rate of dementia in Parkinson's disease. But, you know, kind of right in the middle of all of the estimates is about 1/3 of folks at any given point in time during the course of their Parkinson's disease have dementia. But this includes prevalence, means how prevalent, how common is something at any given point in time. And so this is not saying that 30% of people in their 50s or 60s necessarily have it. This is taking in data from people who are in their 70s, their 80s, their 50s, their 60s. It's like across the board, about 1/3 of folks may have some degree of dementia. There are some risk factors. And one of the biggest risks for dementia, regardless of whether you have Parkinson's disease, is actually age. The older you get, the more likely it is you're going to get it. But as one of my favorite patients would say, yeah, but getting older is still better than the alternative. If we see earlier evidence of cognitive impairment, meaning closer to the time of diagnosis of Parkinson's disease and the person is younger, then the concern exists that, hey, we could see some additional cognitive decline that could be a risk for dementia. And then if we have any significant depression, if we're experiencing neuropsychiatric issues like hallucinations or delusions, that's also a risk factor that we've really got to keep a close eye on that cognitive functioning. There are some protective factors as well. I say lifestyle, and that's a broad term, but if we have two individuals who are the same age, and one person exercises regularly, eats healthy, doesn't drink, doesn't drug, doesn't smoke, and then the other person drinks, drugs, smokes, doesn't exercise, and doesn't take care of themselves, I think you know which of those two individuals would be at risk of cognitive decline. Another protective factor is actually what we call cognitive reserve. And basically, some people are just born with a little bit more fuel in the tank. And for those individuals, that's a protective factor. If a dementia is going to come for them, it has to work a little bit harder to burn through some of that fuel. Next slide, please. So look, if you remember the slide with the yellow arrow and the boxes, if we end up in that pink box, that doesn't mean, oh, okay, well, we're not gonna try anymore. We're not gonna do anything about this. What it means is we're gonna talk. We're gonna talk about what are our options and what are some of the things that we want to do. There are medications that are designed to slow progression of cognitive decline. In the 2000s, Exelon was a medication that was FDA approved. It was actually the first FDA approved medicine for Parkinson's disease dementia. Nice thing about Exelon is it can come as a patch. And so if people don't like taking medications, or if they feel like they have so many medications that they're eating a handful of Skittles every day, sometimes it's nice to not actually add another pill. But what we're also going to talk about is physical, mental, and social activity. I'm going to talk to you about physical therapy. I'm going to talk to you about occupational therapy. I'm going to talk to you about speech therapy. I'm going to talk to you about big and loud and exercising. The law of inertia has two parts to it. An object at rest tends to stay at rest, but the other part is an object in motion tends to stay in motion. So we are going to come up with a game plan to make sure that you do everything you can to stay in motion going forward. We're going to get help from family, from friends. We're going to loop a whole bunch of people in and get all hands on deck. Next slide, please. Oh, and okay, well, perfect, because I see a question just popped up from Robert. So here's what I will say about over-the-counter medications. I'll say a few things. One is, if they're not FDA approved, then there's no guarantee that the active ingredient is actually in there, or in there at the dose that they say it's in there. Further, they haven't undergone rigorous clinical trials to prove that the medications actually do what they say they're doing. If people feel like, oh, hey, you know, I want to talk to my doctor about it and make sure they don't have any contraindications, they likely won't have a problem with it. They will just probably say, I'm not sure that it's anything more than placebo. That being said, another one of my colleagues will say, look, a big part of medicine is placebo. So if it's not financially draining, if it's not giving you any unwanted side effects, and if your prescribing providers don't have any problem with it and you want to try it, it's probably not going to be harmful. But whether it actually does what it does, we don't know. Okay, great. So I want to shift gears to talk about some emotional considerations in Parkinson's disease. And I've separated emotional from neuropsychiatric primarily due to the severity of the neuropsychiatric as opposed to emotional. And so actually another question just popped up that I think is relevant to the cognition section. So here, that's a question. The question says, how do we know if we have Parkinson's, dementia, or Lewy body? So that's also another question that I ask my residents. There can be some pretty clearly differentiating factors between Parkinson's disease, dementia, and dementia with Lewy bodies. They are typically a lot better differentiating early in the disease process. In a Lewy body dementia, very often we see things like hallucinations early on, and in the absence of any medications for the Parkinson's disease. Very often the hallucinations are visual. We tend to see fluctuating alertness throughout the day. So there will be periods of time where the individual with Lewy body dementia is doing okay, interacting meaningfully, and then all of a sudden it's like, now the lights are on, but there's nobody home. They're not responding. It's not just their attention is off, it's just that they're not really alert. We tend to see this thing called a REM sleep behavior disorder, which I'll touch on later, where we see very vivid, lifelike dreams. We see acting out of our dreams. There's thrashing in the sleep. But actually the best differentiating factor between a Parkinson's disease dementia and a dementia with Lewy bodies is the onset of symptoms. So if the Parkinsonism, whether it be the tremor, the rigidity, the akinesia, the postural instability, whatever it may be, that is present for at least a year prior to the onset of any cognitive issues. If the cognitive issues emerge first, and then we see symptoms of Parkinsonism, that's a concern that we could be looking at a Lewy body. Now, if we have significant disease progression, I'm talking, years, the two tend to sort of overlap quite a bit. And so it's really the early onset of symptoms that tends to be the best differentiating factor. And then someone said, are any of these kinds of cognitive impairment more predictive of developing into dementia? So that's a really good question, Ed. Depending on the pattern of cognitive deficits, the answer would be yes. So for example, there is this condition that we call amnestic, so memory-based mild cognitive impairment. For mild cognitive impairment, that is not purely memory-based. So we might have some mild weaknesses in a few domains. Memory could be one of them, but if it's in other domains, the conversion rate at 1 year to a dementia is about 10 to 16%. If it is a memory-based mild cognitive impairment, the conversion rate is above 20%. But that's why it's important that we get this type of evaluation done to figure out, okay, where are the cognitive strengths and weaknesses? Let's get a good baseline evaluation. I mean, we don't have crystal balls, we can't predict the future, but there are certain kind of red flags that we look for in these evaluations. Could we do the next slide? So, emotions, right? These are these internal feelings that we have, and there can certainly be a wide range. And it's normal to experience a wide range of emotions. And emotions in and of themselves are not necessarily good or bad, but there can be some clinically significant emotional experiences that we have. And so if we can go to the next slide. About 50% of people who have Parkinson's disease develop clinically significant symptoms of depression and anxiety. And by clinically significant, I mean that it's impacting your functional status. It's impacting daily life. These aren't, you know, the blues or feeling a little bit down. This is legitimate depression and anxiety. We can also see development of this syndrome we call apathy. And apathy can be a symptom of depression, but interestingly, in a substantial portion of people who have Parkinson's disease where there is no actual depression present, they actually have this thing we call apathy. It's a lack of motivation and initiation. And I'll talk more about apathy in a couple of moments. But the other thing we have to consider is we all experience adjustment reactions. And when we get big news or sad news or tough news, it can be perfectly appropriate to take a little bit of time to process something. And so one of my old mentor's favorite sayings was, well, before you go diagnosing somebody with depression or anxiety, first make sure they're not just surrounded by idiots. And so his point was, let's consider the circumstances of where people are. Next slide, please. So assessing for depression and anxiety and Parkinson's disease can sometimes be a little bit challenging. So if somebody comes into my office and they have depressed affect, it could look something like this. Anybody ever seen masked faces, hypomimia in Parkinson's disease? If somebody has what we call psychomotor retardation, if they're moving or speaking slowly, that can be a sign to me that, oh, some depression could be present. In Parkinson's disease, that could be the bradykinesia. If I have somebody who has a pretty significant tremor, I mean, some people might think, boy, is that anxiety? Well, you can have a tremor in Parkinson's disease too. And so very often what providers are doing when they're assessing for depression and anxiety, for emotional concerns, is they'll give you those questionnaires that you fill out at your primary office or at your neurology office. Over the past 2 weeks, how often have you been bothered by any of the following issues? But the reason they do that is because they want to dig a little bit and make sure they're not missing anything. And very often the providers will actually say, hey, you know, I think I want to refer you to social work or psychology or a psychiatrist, just to meet with them and get a feel for how things are going. Don't, you know, interpret that as a sign that anybody thinks you're crazy. It's just, hey, we want to know if any of these things are present because they deserve to be treated and improved. We do the next slide. Okay, there are also treatments that we typically recommend if we have clinically significant depression and anxiety in Parkinson's disease. There are behavioral things that can be done. There is this great therapy out there called cognitive behavioral therapy. It's evidence-based, it works. What it does is it changes the way you think about certain situations because it's our automatic thoughts about situations that result in various emotions and then behaviors. And it just really teaches you how to change the way that you automatically think about different situations. And it works, and we know it works in Parkinson's disease. And this is going to be a theme that you're going to notice: physical, mental, and social activity. We want to keep you well-oiled. We don't want you rusting up like the Tin Man. And we know that the physical, mental, and social activity are actually incredibly good, not just for your physical health, but also for your emotional health. And if you're of the camp that you would be open to potentially looking at pharmacological interventions, there are some medications that we can talk about. The newer generation medications, some of the newer SSRIs, they have, for most people, very minimal, if any, side effect profiles. They don't interact with other medications that most folks are taking. And they can be very beneficial in terms of kind of giving people a little extra oomph to participate in some of the behavioral strategies to address the depression and the anxiety. Can we go to the next one? Okay, so I mentioned apathy. So this is a lack or a loss of motivation or initiation. Dopamine is involved in our reward pathways. There's this pathway, this circuitry in the brain. It's called the mesocortical limbic dopamine pathway. So we'll just say it's a reward pathway. And we don't have dopamine fueling that, okay? And so there's kind of this lack of reward that can be associated with different activities. If you typically do something and you feel good about it, that's partially because dopamine is fueling this reward system. If we don't have that naturally occurring dopamine, we don't really have the fuel for this system. But we also have to think about, in Parkinson's disease, as it progresses, we lose some of our physical abilities. Sometimes we lose the ability to participate in some of our hobbies. And that can be kind of a bummer, right? My neighbor, who unfortunately passed away from Parkinson's disease, one of his favorite hobbies was tying flies and fly fishing, and he lost the ability to do that. Very often, though, when we see this lack of initiation, how it's typically described to me when I'm interviewing somebody is, Bob is content to sit on the recliner all day long. But interestingly, if I get him up and moving and I get him doing something, he actually does it okay. He just doesn't seem to initiate. It's sort of like the engine in the vehicle runs. It's just not turning over. And so what I really encourage family and loved ones and supportive caregivers to do is be that jump start. Get the person up and moving. You don't want to push too hard, but let's gently encourage and try to get the person up and moving, because very often we can actually carry out a lot of the tasks. It's just the initiation piece. I'll talk about big and loud, rock steady boxing, cycling, various types of exercise, enjoyable activities. Let's get you up, let's get you moving, let's keep that body in motion. Okay, next slide, please. Honestly, I think I can monitor for the questions. So at any point in time, if anybody has anything they want to throw up on the chat, I will certainly try to address that. Okay. Okay, so neuropsychiatric issues. Who is best to provide CBD for patients with CBT. Yeah, so okay, all right, Kelly, I wasn't sure what we were talking about there for a minute. So there are lots of providers, pretty much anywhere you are. There's got to be folks who are close. Whether they're actual psychologists, social workers, counselors, etc. Lots of people get the evidence-based training in cognitive behavioral therapy. An easy thing to do is if any of the mental health organizations have websites, they often have biographies for their different providers. They list what types of services they provide. There's an organization here in town. It's called Psychology Associates of Grand Rapids, and they're fantastic. You can call and talk to the receptionist and just say, hey, do you have anybody who does cognitive behavioral therapy? And she'll give you a list of the people. Pine Rest is a great organization. They have biographies on their website. But for most of these organizations, depending on where you live, whether you're toward the center of the state, whether you're Grand Rapids, north, south, southwest, it's pretty easy if you call your primary care doc and say, hey, who do you know? Who do you got? Also, your neurologist will typically have kind of some of their go-to people who can provide this therapy. Okay. So neuropsychiatric issues, these I said I differentiate from emotional issues primarily due to the significance and the severity. So first, hallucinations and delusions. Hallucinations are abnormal sensory experiences. We have 5 senses, right? So sight, hearing, smell, taste, and touch. We can only have hallucinations through those sensory modalities. Delusions, on the other hand, have to do with abnormal thought content. The reality testing isn't intact. And so I don't know what's going to happen with college football, this particular season. But what I usually say is, any Michigan fans in the room, and a whole bunch of hands go up, and I say, of you people, how many of you think that Michigan will actually beat Ohio State this year? And whoever leaves their hands up, boom, there's an example of a delusion. It's just not realistic. I wonder how many people are going to cuss me out on the chat for that one. But the point is, these issues can be pretty debilitating. Very, very stressful for the person with Parkinson's disease, very, very stressful for family, loved ones, and caregivers. Can you go to the next slide? Yeah, so a question just popped up. Do increased PD medications increase either hallucinations or delusions? They can. They certainly can. And I'll probably address that a little bit more in this particular slide. It is certainly possible to have hallucinations and delusions in other neurological conditions. We can have it in Parkinson's disease, even in the absence of, go green, even in the absence of Parkinson's disease medications, but that is a significant risk with increasing some of those medications, yeah. If we are going to see hallucinations, they are almost always visual. In fact, about 95% of the time, we only see visual hallucinations. These are typically well-formed people in your house, people on the front lawn, animals, things of that nature, deceased loved ones. Occasionally, as a precursor to those fully formed hallucinations, we can see people talk about, oh, you know, I have these illusions where I think it's an animal and it's actually a pile of clothes when I look at it. Or sometimes I see a shadow moving across the floor. We really try to dig on those things to try to catch the earliest possible signs. Second most common type of hallucinations are auditory, but in the vast majority of people who have auditory hallucinations, we also have visual hallucinations. Right? When we talk about delusions, they're actually typically paranoid. You know, my significant other is cheating on me, family is stealing from me, people are plotting against me, etc. More so than cognitive issues in Parkinson's disease, more so than the motor symptoms and motor progression in Parkinson's disease. The greatest risk for not being able to live at home anymore are the hallucinations and the delusions. That's the greatest risk for placement in an alternate living facility. So first, we have to look for reversible causes. It can be something as mundane as a urinary tract infection. That can throw us for an absolute loop and we can experience psychosis. We could have some type of metabolic process. There could be some type of infection going on. So typically some lab work is going to be done. They're going to do an exam with you and just kind of see where everything's at. There are other non-Parkinson's disease medications. There are some benzodiazepines. There are some medications people can take for sleep that can sometimes cause the hallucinations and the delusions. And certainly, to the point earlier, yes, some of the Parkinson's medications can actually cause the hallucinations. There is a very specific decision tree that providers will go through with regard to, okay, we know we really need the PD meds, so let's make sure it's not one of these other things. And as a last resort, we could potentially have to look at changing some of those PD meds. And for some folks, we're just left with these residual hallucinations and delusions, and we might actually need to talk about potentially going on low-dose antipsychotics. But that's really the last resort, and that would be through discussion with neurology and potentially psychiatry. So Vicky popped something up there. Kelly, is there any way that folks might be able to send any more personalized or in-depth communications to you so that I can follow up with them individually?
Sure, absolutely. I'll put my email address in the chat so people can contact me. If you have something more, like Dr. Bertram said, detailed, that we have to do a little deeper dive on to give you feedback.
Thank you for that. So yeah, let's, Vicki, make sure you follow up with Kelly and then we'll be able to touch base. So the REM sleep behavior disorder that I had mentioned earlier, a significant number of people with Parkinson's disease do develop this, and it's not Lewy body dementia. It's the REM sleep behavior disorder in the Parkinson's disease. This is the vigorous movements, the acting out of dreams. Sometimes there's yelling, there's verbalizations. Sometimes it's disruptive for the person with the sleep issues, but it's almost always disruptive if there's somebody else in the bed. If I'm not sure if somebody might have like a mild REM sleep behavior disorder, I'll often refer for a sleep study. You know, with technological advances, sometimes what I'll say is get a video on your cell phone, show me what it looks like. Okay, and then sometimes we can forego the sleep study. But at the end of the day, we need to address this. We need a good sleep at night. If we have Parkinson's disease, we need our rest. If we're a caregiver to somebody with Parkinson's disease, we need our rest. And so what we would talk about is, well, first things first, let's get a safe sleep environment. If the issue is smacking hands against the wooden headboard, let's get some padding on there. If we're knocking over a nightstand, let's go ahead and move that thing further away from the bed. If we're elbowing our sleep partner, maybe we talk about getting a nice full-length body pillow in there. But, you know, at some point, we might need to do either separate beds or even separate rooms. There are certain medications that can be useful for this. Good old-fashioned, over-the-counter melatonin, that can get the job done. And very often, that's what our providers will actually recommend. There's a benzodiazepine, and I had mentioned those earlier that we have to be careful with them, but that's the clonazepam. And typically, that's if we don't get any benefit from the melatonin. A lot of folks respond really well to the clonazepam. It just tends to mellow everything out and kind of allow you to overcome this lack of paralysis while sleeping. We do the next slide. Okay, we can go to the next one. So look, these were just a few of some of the non-motor symptoms that we can experience. There are a lot more out there, but these are really in the wheelhouse of neuropsychology. But hopefully, you know, as some takeaways, you can just be mindful that Parkinson's disease is much more than just a movement disorder. There's a lot more going on. We have to investigate and treat these non-motor symptoms because they can be incredibly debilitating. They can directly impact your quality of life. So that same mentor said to me, first sign of trouble, get help on the double, right? So if any of these things are coming up, speak up. Let your providers know what's going on. Let's get these things figured out, and then let's address them. And somebody said, does REM sleep behavior or REM sleep behavior disorder occur outside of PD? Now, the answer to that is it depends on who you ask. But if we have a concern about a potential REM sleep behavior disorder, I would do what my mentor would say. Let's speak up and ask somebody about it. Some people would say, no, it does not. And some people would say, yeah, but it's kind of rare. And then some people would say, oh, yeah, my uncle's got it. So my advice would just be probably get it checked out. Okay, can we do the next slide? Okay, so again, I want to be sensitive to time, but if you'll allow me to indulge just a little bit here. So a couple of things that I'd like you to take with you. Winston Churchill is often credited with a saying that I particularly enjoy. The saying is, if you're going through hell, keep going. Right? It's not a place that you want to settle down. And there are going to be times where it absolutely feels like you're going through hell. Keep going, rally the troops, get your support system in place, let people know what you need. The second thing that I wanted to share with you was what I call the pep talk. And so now I'm going to ask you to really indulge me, but this is meaningful, I promise. So there's a little story behind this. 2 years ago, with a 3-month-old and a 3-year-old, my wife and I thought it would be a great idea on the last Saturday of summer to take the kids to Shedd Aquarium in Chicago. We it was probably not a great idea. But anyway, so we did it. We stayed outside of Chicago, and then we got there right when they opened, and we were having a great time. You know, the baby was sleeping, and Harrison, my now 5-year-old, he loves fish. He loves ocean life, and he was having a great time. And then at about 11:30, maybe 11:15, Harrison started losing his mind. He was all over the place, and we couldn't figure out what was wrong. And then all of a sudden it occurred to us. Time change. Harrison eats every day at 11:30 Eastern Standard Time. And within 15 minutes of him not eating, he gets the hungry angries, the hangries. And so it's you know, pushing 11:30 now Central Time, so it's 12:30. He's an hour late. Oh my gosh. So we go to the cafeteria, and you know, the line was long. If you were at the aquarium cafeteria that day, you heard and saw Harrison. So eventually we just said, okay, it was a great couple hours. Let's get them out of here. So the series of poor decisions continues. We stopped at McDonald's during the lunch rush hour in a Chicago suburb. My wife stays in the car to feed Daniel, the baby at the time. And if anybody has kids and you think back to going on road trips with 3-year-olds, what's the first thing that you do whenever you stop somewhere? Take them to the bathroom, right? Well, good move, Dad. I didn't. I got us right in line. It was standing room only in this place. The line was, you know, all the way through the restaurant. And so we were waiting in line. We're next in line, okay? And Harrison tugs on my shirt and says, Daddy, I have to go to the bathroom now. So I take him to the bathroom. By the time we come back out, we're not next in line. But they're shorthanded, and the manager's running all over, and customers are getting crabby. We finally place our order, and I'm standing kind of next to the counter, but I'm about 10 feet away from a young man who is putting together burgers and sandwiches just at a furious pace. And as I'm watching him, and I'm listening to some of the things that he's saying, this is not a stereotype, this is me, I observe behavior. I can tell he has some type of a developmental delay, and he is getting very, very overwhelmed. And he's saying things like, you know, to the manager, please, I need some help, I can't keep up, I can't do this. And I remember really feeling for him in the moment, thinking, gosh, this has got to be tough. And people are barking orders at him, and customers are complaining, and I'm watching him, and I'm thinking, oh boy, you know, this is not boding well. And at one point, he puts his hands on the counter and he pushes himself back. And for a split second in my mind, I thought, he's walking out of here. He's walking out. So instead, what he does, he puts me in my place. He takes a deep breath. He goes, come on, Charlie, you can do this. And he gets right back into it and starts throwing together those sandwiches. So my point is this. There are going to be times where it feels like you're going through hell. You need to keep going. There are going to be times where you feel overwhelmed and like you just can't quite get through this. Whether you think of Winston Churchill, whether you think of Charlie at the McDonald's in the Chicago suburb, whether you involve family and providers and friends and caregivers, do what it takes to keep going. And if we can go to the next slide. So here are the boys. Okay, so they're on the left side, that is Daniel. This is actually pretty close to the time that we took him to McDonald's. So Daniel is a few months old in that picture, and there's big brother Harrison feeding him his bottle. And then on the right, this is about at the same time also, they're having a little snuggle in bed. And if you go to the next one, this is just a few weeks ago. That's Daniel on the left, and Harrison. Harrison is supposed to start kindergarten in 6 days. We'll see if that happens. So he doesn't quite read yet, but he recognizes some words, and he's familiar enough with the books that he can sort of read them to Daniel because he has a fantastic memory, and we've read them so many times. So that's the brothers getting along. That's about 5% of the time. I don't take pictures the other 95% of the time. But anyways, that is what I have for you. And for those of you who were able to stay on. Hopefully all of the blabbering was worth it in order to see the two good-looking boys.
Thank you, Dr. Bertram. Your talk was excellent, and you allowed really great time to kind of pause and allow people to ask questions as you went through these categories. So excellent talk. Are there any outstanding questions from anybody on the line still?
If you have a question, just go ahead and unmute yourself.
This is Kelly. I do have a question if nobody else is speaking. The only one I want to ask is regarding a baseline assessment for patients. Is it pretty encouraged for most patients with Parkinson's to have a baseline, or would you wait until somebody's having some decline or some concerns like hallucinations, or having that discussion with their doctor where something's raising more of a red flag?
Yeah, you know, we always say, gosh, wouldn't it be great if we had a baseline on everybody? But that's simply not practical. Mm-hmm. I stand by the adage of, you know, first sign of trouble, get help on the double. I think, you know, at least with the providers that we have at Spectrum, we've sat down and kind of talked about at what point do we want to get that baseline evaluation. And you know, it's typically when either the patient or a family member has noticed something that maybe seems a little bit off. Very often our neurologists will do brief cognitive screenings. And if anything catches their interest, they typically go ahead and send folks over. I wouldn't say that you necessarily need to get a baseline evaluation, you know, as soon as you're diagnosed with Parkinson's disease. Unless you're motivated to do it, if you have any type of family history of cognitive decline, really feel it out is what I would recommend with a neurologist. Hey, do you feel comfortable screening me real quick? Or, you know, do you think we need to pursue this now? Do we want to wait a little while? I think it's very much a conversation that's appropriate to have with the diagnosing and treating provider. I can tell you that if you work with any of our 4 folks who handle the lion's share of the movement disorder referrals, our 4 neurologists, they'll tell you it's just a matter of time before you're going to see one of our neuropsychologists.
Thank you.
Thank you.
Sure.
Dr. Bertram,
Yeah.
this is Mary.
Oh, and there's the CBD. With regard to CBD, you know, I believe that if something works and it's not causing you or anybody else harm, then it's very much worth discussing with your prescribing medical providers. My advice to most folks is, if it's on your mind, have the discussion. Make sure that it doesn't appear medically contraindicated, make sure that it appears safe, and then see what they have to say. I can tell you that there's going to be a whole lot more research on CBD with legalization. It's going to be researched not just in terms of medical factors, but also psychological factors. And I don't think it would be hard for somebody to come across somebody who says, the CBD really helps with my anxiety. I don't think that would be surprising to me at all. But it's definitely a conversation to have with the prescribing medical providers.
Dr. Bertram, this is Mary Sue Lanigan. I'm with Michigan Parkinson Foundation. I want to thank you. This was an outstanding presentation. It was just really good practical information. One of the things that I love that you mentioned was the importance of social interaction, exercise, connection with others. And we've been really pushing the exercise. I don't know if you're aware of this, I know Kelly is. For all of you on this call, we are providing exercise every morning, Monday through Friday at 10 a.m. on Zoom. And the classes are taught by physical therapists who specialize in neurological disorders. They teach the program called Power Moves, which is Parkinson Wellness Recovery. And it's an exercise program that was developed for Parkinson's. And then 2 days a week we have yoga, but they're always at 10 a.m. Monday through Friday. So if you're not participating, I would really encourage you to check it out. It's free of charge. You can go to our website, and the class schedule and the Zoom link is located under the exercise section on our website. I'm going to put it in the chat box right now, the website.
Thanks for sharing that and reminding the group of that. We are going to be sending out in the next week some updated information about exercise options as we continue to do things more remotely. We want to make sure everybody has access to these great resources and they know where to find them and how to access them live or recordings. So we will send that. And there was a question here about this being recorded. It has been recorded tonight. It is posted on the Michigan Parkinson's Foundation website, and I will send a link to the group as well. Anybody who has our Spectrum support group email, so you can view this, or some people have already asked me in advance if they can have it sent after. So I'm just going to send it to everybody on our distribution list.
Could I ask a question?
Yes.
Please.
Okay, I'm Adele Pleatman. And for people who are young onset Parkinson's, does age have anything to do with the dementia? Like, if I'm younger than the average Parkinson patient, does it fall later as you age?
Yeah, so very often, we have to consider the risk factor of age with regard to cognitive decline. A lot of times our young onset Parkinson's patients, those are the folks that I would really say, okay, if we feel like there are any even subtle cognitive changes, let's go ahead and get a baseline evaluation early on. The very nature of a young onset Parkinson's disease can sometimes be accompanied by, obviously earlier changes to a lot of the physical functioning. And I think for those particular individuals, I like to get an early cognitive evaluation because we're talking about early onset of the disease, and we could be dealing with this for a significant amount of time.
Okay, and the reason you want to catch it early, I'm not quite sure, like can 6 months go by before you attend to it, or?
Oh yeah, absolutely. There are very few, reasons to pursue an urgent evaluation. And this, I would say, could just be absolutely routine. Sometime within the first year would probably be ideal.
Okay, thank you.
Yeah, absolutely. Great question. Thank you.
We are right on time here. It is 8 o'clock, so we appreciate everybody's participation tonight. We had 92 people here this evening, so that's an excellent turnout and shows great interest for this topic. Thank you so much, Dr. Bertram, for presenting so well and so thoroughly. And thank you again to the Michigan Parkinson's Foundation.
Thank you, Dr.
Yeah, thank you, everybody. I really appreciate it.
Yeah, we are so grateful. This was just outstanding. I know we're going to get a lot of requests for this presentation.
Now, if we can just get the video.
Again, thank you. All right, folks, we are going to sign off. It is a gorgeous evening here in Metro Detroit. I hope it's the same wherever you are, so enjoy the rest of your evening.
Go out and catch some Lyme disease.
No!
Thank you, everybody. Good night.
Thanks, everybody.
All right.
Good night.
Good night. How do I leave this? Leave and.